So today we are going to deal with the ophthalmology instruments, and my purpose to deal with the ophthalmology instruments are dual. Like you know that so many times in the practicals and the viva these instruments are kept, and you have been asked to identify the instruments and you have to tell its uses. But the second reason why I want to discuss the instruments is that while you are going through the theory of ophthalmology, there are so many procedures that you study, there are so many steps that you are studying. So it becomes slightly cumbersome to understand those surgeries or to understand those steps until and unless you have the sound knowledge of the instruments. So let's begin with the first one. So in the first one, I am beginning with the very basic instrument, and that is one instrument that you use a maximum of the times. So can you see this? What is this actually? This instrument is a universal speculum. It is called as the speculum. Now the reason why it is called as universal, because you know when we use other speculums we have to use separate, like we have to use separate for the right eye, separate for the left eye. But this speculum can be used in the either eye. So that is why it is called as universal speculum. And what is the actual purpose of the speculum is to widen the eye. You have to open the eye so that you can do the procedures. So this can be used for the very basic when you are doing the enucleation surgery, the evisceration surgery, the destructive procedures. Then a very common thing that you see in the OPDs, that you have to remove a foreign body. Now what happens when there is a foreign body, maybe in the conjunctiva or in the cornea? Obviously there is lot of lacrimation, lot of redness, congestion, patient is in pain. So it becomes difficult for the patient to open his eye wide and let you remove that foreign body. So for that purpose we also require the eye speculum at the time of removing the foreign bodies. And I think this is one of the very common uses of the speculum, because every day when you are there in the OPD, I think there must be some patients, and everybody who is posted in the OPDs or who has already passed or maybe doing the internship posting in the opthal will agree to me that like foreign body is one very common case that you get in the opthal OPDs. So that time also we use it. Then third thing, another important thing is the corneal ulcers. Like we have got a lot of cases of the corneal ulcer, especially the bacterial ulcers. So at that time also, when we want to do the cauterization of the ulcers, we want to remove this corneal debris, then also we use these via speculums. Okay, so first of all, let's go through it. It is a universal speculum, can be used for both the eyes, and it is used to separate the eyelids when you are going under, your patient is undergoing any intraocular surgery. One very important advantage of the speculum is that it is self-retaining. Otherwise, you have to get hold of some person, a person assisting you, you actually will hold this. So it's self-retaining, so you independently can do it, and it's very lightweight. So patient compliance is again very good. So whenever you are doing any intraocular surgery, extraocular surgeries, you require this speculum. So that is the purpose I started with this, because the moment you are into the procedures, whether it's in the OPD or whether it's in the OT, you have to know this. Alright. So this was your first one. Now let's see the second one. This is what you called as a forceps. Now you already know that what is a forceps and what is a scissor, right? So you have to actually concentrate on the tips in order to find out that what kind of forceps it is or what kind of scissors it is. So looking at the instrument, can you see this is a forceps? So we already know this. Okay, now in order to identify, see back, that is the handle portion, can be different. Maybe it can be due to the manufacturer's quality and designs. So basically for the identification, never go and see the handles, always see the tips. So it is actually the tips that will help you to identify the instruments, and that is the basic secret, or I can say the basic logic of identifying the instrument. So can you see a very important tip to remember this is, can you see the S-shaped curve here? So this S-shaped curve is actually because it is a superior rectus holding forceps. So you are getting a double curved at the end. So S for S, remember that you are getting the S-shaped curve in the superior rectus holding forceps. All right. So what you are getting, a very big tooth, you are getting a very big tooth in this portion you are getting, so that you can get hold. It is something like this. So this S-shaped curve is having a single tooth here, so that you can hold whole of the superior rectus belly. And you know, if you remember, like now how to apply your theory, whatever you learn in theory is just not the cramming it up, you have to apply it. Now if you remember what we learn in Mills, what was it? It was 5.5, 6.5, 6.9 and 7.7, right? So these were the distances of the rectus muscles which were from the limbus when they are inserting into the sclera. So can you see here, for the superior rectus it is 7.7. So what is its first angle at? So where it is bended? It is bended at a distance of 7.7 mm. So can you see the logic? So you don't have to cram it up, because you already know that the distance of the superior rectus from the limbus is 7.7 mm. So, when do you require this superior rectus holding forceps? Obviously, when I want to lift the superior rectus and I want to pass a bridle suture, right? When do we have to do it? A very common thing when we are doing the cataract surgery. What happens when we do the cataract surgery? Suppose this is the eye here. Okay, so if this is the superior area, why I am saying this is the superior area? Because as a surgeon, we are actually standing on the head end of the patient. So patient is lying like this in front of me, and suppose I as a surgeon is standing here. So I require this area for doing the incisions and the other things. So I require this area. For that I will have to lift up the superior rectus. So for that purpose I will use it, not only for the cataract but also for the glaucoma surgery. Then another important thing is, when you are doing any other surgery, maybe you may be requiring the stabilization of the eyeball. I think that's a very important thing. The moment you want to do anything over the eye, the first important challenge is the stabilization, because you cannot manipulate, you cannot do anything over the eyeball which is not stable. So you want to pass a superior rectus bridle suture, be it the cataract surgery, be it the glaucoma surgery, or you want to stabilize the eyeball, then we are using this S-shaped, S for S, superior rectus, having a bend at 7.7 mm. Is that very clear, right? All right. Now see this. Now can you see, this is not a forceps, okay, this is a scissor. Now it's a typical kind of scissor. Can you see? It is not looking like a normal scissor we have. So this is actually a spring scissor. It is a conjunctival spring scissor, and as far as the tip is concerned, we can have a sharp tip or a blunt tip. Now, why this is called a spring scissor? Spring scissor means this scissor is working with a spring. So, can you see here? Can you see here? The blades are actually apart like this. Why? Because there is a spring action. So, when we are actually cutting the conjunctiva, see, for making the flap, you require that spring action, otherwise it will be becoming very traumatic kind of dissection when you want to make a conjunctival flap. And so it's used. See, in order to cut the conjunctiva for making the conjunctival flap. So, for this, you already know that what are the steps of the cataract surgery. This is the first thing that we keep on learning while we are doing the lens and the cataract, that first you have to make the incision, corneoscleral incisions, and for making that you have to do the cutting of the conjunctiva. So, now you can correlate. For this I require a spring kind of action, right? For that it will be easier. Like for example, if you remember in our first years when we used to do the anatomy dissection, some amount of dissection that was called as a blunt dissection was done by our fingers only. So, can you see, this is again a spring kind of action that we used to do for the blunt dissection. So, in eye, the blunt dissection obviously cannot be done with the help of a finger. So, here we are using this conjunctival spring scissors. So, if you remember its name and if you see its tip, this moment you see the open tip, you will remember that it is like this. That is the spring action. Alright. Now we come to the other one. Now what is this? Now again you can see that this is a forceps. So half of the name you already know that this is a forceps, and if you look at the tip, what is this? Now can you see the tip is not sharp? It is not having any tooth. That means it is not for any dissection, it is not for lifting anything because of its blunt ends. Can you see, they are just like hands, like if you hold anything with hands, the shape is something like this. So this is actually your globe fixation forceps. Though it has got tooth, but they are at its inner tip, and if you see from the outer aspect, they are just like this. They are holding the globe from both the sides. So basically their use is the stabilization of the globe. And why we actually require this? As I told you that the moment you want to do anything over the eyeball, stabilization is very important. So when I want to hold the conjunctival tissue for cutting, or when I want to make some conjunctival flap, so all that time, or when you are making a tunnel, like when we do the SICS and I want to make a tunnel, so that requires lot amount of intervention there, lot of manipulations there. So first we require, what you require is the stabilization of the globe. So for all these purposes we are using this globe stabilization or a fixation forceps. Alright. Now see this. I think this is easy to remember as well as to identify. Can you see the electrical part here? Right, we have this electrical part, and this is very commonly used in the cataract surgery. The moment you give the incision, conjunctiva being very vascular, a lot of bleeding can take place, and one of the intraoperative complication that you study in cataract surgery is the irregular bleeding, especially in those patients who are having hypertension, especially the uncontrolled hypertension, or they are having some heart disease. The amount of bleeding is very high here, and in normal people also, because conjunctiva is a vascular tissue, so when you are giving an incision, the bleeding is expected, so you have to achieve the hemostasis. So how will you achieve the hemostasis? For this we are using the electrocautery, and this is given along with this wire. Sometimes we also call it as bipolar diathermy. Bipolar means it has got two poles, and on both the sides the wire is there. That's why it is called as a bipolar. So whenever you are making a conjunctival flap, there is a bleeding from there, you are using it. Can you see here the two blades which are coming out? They are again just like a forceps here, because they have to be applied over the conjunctiva, and they should not be very pointed. They should not be having any tooth there, so that you do not cause more and more trauma. Rather, they should have some gripping capacity, so that what you are doing when you are putting the wire in the electrical socket, you are switching it on and you are actually touching it, so it should be able to hold the vessels between the two prongs. So it should be like this. That is why they are in the form of holding hands position. So the one is like this and the other one is like this, and the tissue can be compressed in between the two. All right, so this is your cautery. Then coming to the next one. Now this is the one very common thing, everybody recognizes this. We have got a blade and a handle. So I think this is the first instrument that we hold in the dissection hall, and I still remember the moment this handle and the scalpel and the blades comes in our hands. From there we start feeling that yes, we are a medico, and like a lot of people are there which gets like a kind of a shock from this, and we have seen so many people getting syncopal attack on the dissection table, seeing these blades, or when they see for the first time blood shedding in the OTs. So this scalpel and a blade, so how you are using it, this is called as the Baird Parker knife handle with a blade. Mostly the blades that you are using, they are like 11 number or they are 15 number, and basically this blade is for giving the incision. So obviously whenever you are doing the intraocular surgery, you have to give the incision, so we are using these blades. And the important thing is that when you give the incision in the eye, especially for the intraocular surgery, your hand should be very stabilized. Like you don't have a large surface area to give the dissection here, to give the incision there. So your work space is a very limited. So you have to go according to that only, and it's better if you hold that blade in a pen holding manner like this. The reason is that you have a better grip when you hold the blade in the form of a pen holding manner, and we have a command over the steps that we are doing, and we can give the incision. But if you are holding it like this, like our hand becomes let loose and there can be irregular incisions. So that's a good idea of keeping this blade in a pen holding manner. So what are its uses? See, the first and the most important use I will say is to make the corneoscleral incisions in the cataract surgery. In fact, the most commonly used done surgery in the ophthalmology. But at the other places also, whenever you are required to give the incision, like it can be DCR, it can be ptosis, entropion, ectropion, any kind of a surgery, we are using the blades. But yes, again, when you are presented in the viva, you are sitting in front of examiner and he asked, then the first thing that should come to your mouth is the corneoscleral incision in the cataract surgery. That is the difference between a theory and a practical. Practical means first thing first. Whatever use is the maximum use or the widespread use of that instrument, it is much better that you give the most important one use of the instrument rather than the other 9 uses. So that is the basic difference. All right. Now see the next one. Now see, this is again a knife. See, this is not a scissor, this is not a forceps. Can you see this? So what is this? This is called as a knife. So if you look, I told you that the tip will always guide its name and its use. So if you see here, what is this? It is crescent shape like this. So there goes its name, very easy. Its name is crescent knife. Its name is crescent knife. And can you see its tip is blunt? Because if it is pointed, then that will be pointing towards another instrument, that will be your keratome, right? So what happens actually in the theory books, many times they write interchangeably because sometimes both can be used, but practically when it comes to the instrument, there is a difference between a keratome and a crescent knife, and you have to see the tip of it. So this is having a blunt tip. So basically this blunt tip will help again in making of a plane. So when you are giving the incision by a blade and then you want to make a tunnel, so for the deeper tunnel, for making a plane in the cataract surgery, you require a blunt kind of a knife. That is the use of this crescent knife, to make the self-healing sclerocorneal tunnels after making the scleral gutters in the cataract surgery. See, I told you that we don't have the facility of this like finger dissection there, blunt dissection. So we have got a lot of blunt instruments in the opthal, so that after giving the incision, we can make an entry inside, AC entry by a smoother pathway. Right. Now, on the other hand, if you see the other thing, see this one. This is again a knife, but if you look at the tip here, the tip is like this. So this is at an angle of 45 degree. Like for example, if you remember, we also use a 15-degree blade. So 15-degree blade we are using as a side port for the side port entry. But this is actually a 45-degree blade. This is called as the keratome, the diamond shaped blade, and this is for the main incision. This is for the main incision, especially when we are doing the phacoemulsification. When we are doing the phacoemulsification. So this is a curved, a diamond shaped keratome, and what is the main use? Main use is when you are making the main incision, especially in cases of the phacoemulsification, and after you have made that incision and you want to make that corneoscleral tunnel, you have to go inside, then we are using the crescent knife. And sometimes we also use like side port blade in order to make a side port entry if your main incision is very small. Like you know, in that phacoemulsification, the main incision is your 3 to 3.5 mm, right? But we can do this phacoemulsification with the smaller incisions too. We can have a micro incision less than 2 mm. We can do the phaco-knit, that is less than 1 mm, with the help of the titanium needle. So if you are giving a very small incision in the phacoemulsification, you require a separate side port in order to do the irrigation. So for the irrigation, aspiration and irrigation, you require a separate port, and for the main you are required this. So at that time we are using one more blade, that is your 15-degree side port blade. Alright. Now let's see. Now another thing that you require in the cataract surgery, like you have given the incision. First of all, can you follow the steps? We have used the superior rectus holding forceps for passing a bridle suture. Then you have given the incision, you have made the gutter, then you have made a tunnel with the help of a crescent knife. We also have made the side port entry with the help of a 15-degree blade. Now what next? Next is your capsulotomy. Right. So what we do there? We do the anterior capsulotomy. We do the anterior capsulotomy. So for doing this anterior capsulotomy, you have to tear the anterior capsule. And what is the name of the dye that we use? That is your tryphan blue. right? This is the blue dye that we are using, and that is why it is advised that those people who are having the color related defects, partial or complete, especially for the blue color, should not go for the ophthalmology residency, right? So many times they are being restricted. So here we are using the blue dye. Now we know that there are two ways of doing the capsulotomy. What were the two ways? Like one way was, if you go with the two ways, one way was that you are actually putting a prick in the center and coming towards the periphery, and then you are taking it round in a curvy linear fashion. So that is called as the continuous curvilinear capsulorhexis. So for that, what you require this bent tip, right? So with the help of this, if you are using it like this and this has a bent tip, you can tear it from the center, come to the periphery and keep on stretching in a curvy linear fashion. That is continuous curvilinear capsulorhexis. Or the other way is that you just get a tear in the periphery here and then you go on tearing in the form of a can opener technique. So whatever is the technique that you are using, like you can use it envelope method or CCC method, can opener method, continuous curvilinear method, you have to use the cystitome. Sometimes what happens that this is not available. So even if it is not available, we can use sleek needle there, and that we can slightly bend with the help of a forceps. We can slightly bend the tip of this. Many a times, like you know, when you are a fresher, you require every single instrument in the tray, only then you can start, but slowly and gradually you start learning doing with the things. So we used to see how SRs can do even with less instruments. So they used to use this needle and they used to just bend the tip somehow with the help of a forceps, and you can use it in the form of a cystitome. All right. Now see another forceps. Now can you see here the bend is not S-shaped, it is much more curved here. The steep curve is present here. So this is the typical, which is called as the Macpherson forceps. So this is actually a fine forceps, right? So sometimes what happens, even we can use this forceps also for doing the capsulotomy, because this is having a fine forceps, like we have got the tips which are very fine. But the basic thing for which this is made is for the suture tying. For the suture tying. So we can actually hold the needle, because you know the needles that you are using in ophthalmology for suturing are the curved needles. It is like this. So basically you require something angulated to hold this suture tying, and taking it besides the tissue that you have to suture, you have to take it like this and then you have to do the suturing for that. Or maybe when you want to hold the IOL and you have to take it inside, so that time also we require the angulated forceps. So basic purpose is for the suture tying and for holding the IOL to take it inside, but at times you know you can use interchangeably. If you do not have the cystitome, then we can use it for the capsulotomy as well, right? Alright, now see this. This is a good instrument which you can easily identify. Can you see we have got a L-shaped instrument. This is L-shape. So this L shape is actually called as L for L, right? Like S for S, that S shape was for superior rectus. This is L for L, that is it's a lens expressor. So it is made in such a way that it is hooking the thing, so that it can hook the lens and it can take it out. That is why it can also be replaced by the muscle hook. I will show you that muscle hook also. Now what is the position where it is applied? So basically if you are suppose this is the eye and you are standing here. So this will become the 12 o'clock position and this will become the 6 o'clock position, right, of the patient. So basically it is putted at this 6 o'clock position to deliver the nucleus in like this. You are putting it, you are hooking the nucleus and putting the pressure over that 6 o'clock so that it can hook it out. So you know, delivery of the nucleus is again important. We will be matching up all the steps of the cataract surgery while we are dealing with the instruments. You have given the incision, then cauterization, then you have made the gutter, the tunnel, and now we are coming for the nucleus delivery. I will show you the instrument that will be used for your hydrodissection and the hydrodelineation. We have seen the suture tying like Macpherson's forceps, that was also there. Then anterior capsulotomy you are doing with the help of cystitome. So I think now when you will read the cataract surgery again, the steps, what is the meaning, it will be easier for you to correlate that how this thing will go on, right? Okay. Now see this, what is this? Can you see here, we have got a hook kind of a thing, it's a hollow is there. So if you see here, it is something which is like this. So the hollow instrument that you see, this is actually called as the wire vectors. This is called as the wire vectors, and you know, wire vectors are actually of two types. Like here, can you see, here we have got the empty area here where you can actually connect a syringe through which you can push the irrigating solution also. Like for example, if you want to do the hydrodelineation, like you know, every time you do the cataract surgery, hydrodissection is a must, right? The basal salt solution with the glutathione is the best irrigating fluid. You have to push it up so that you are separating the capsule from the cortex, right? Now this cortex have to be broken, it has to be separated from the nucleus. Sometimes the nucleus also has to be separated into the epinucleus and the endonucleus. So if that is the case, we can use this irrigating wire vectors. Otherwise, we can use the normal one which does not have irrigation, the normal wire vectors which will not have this portion and it will have just a plain handle. That's why this is actually called as modified vectors, in which loop is made up of a wire and the opening that is there, that opening is very small, 0.3 mm. Right. Now here you can see the posterior end, okay, is having a hollow handle where you can connect with the infusion set, but otherwise we can use the normal ones also. And why it is having such a small loop or such a small opening, so that you can hook that nucleus there and you can express the nucleus out. So like one was your lens expressor, right? Now this is for the those nucleus where you require hydrodelineation also. So for at this stage you have to apply the pressure at the opposite level from your end at 12 o'clock. So I think when you are being asked about these instruments, like they will show you the lens expressor also and the wire vectors also. They can ask you that why it was used at 6 o'clock position and why this is used as a 12 o'clock position. So basically this is used to deliver the nucleus by applying the counter pressure. So in cases of the lens expressor, you are putting the direct pressure at 6 o'clock position in this way and that hook is helping to express. But here when you are using the infusion, you are using the counter pressure technique and you are infusing at 12 o'clock position. All right. Now, after this, we'll be talking about the irrigation. Like you have done the hydro delineation, you have broken down the nucleus, you have expressed the nucleus. Now what about the cortical matter? The remaining cortical matter or the remaining nuclear matter has also to be aspirated, so that you are having completely clear view there and you can go with the IOL entry. So for that we are using the Simcoe's two-way irrigation and aspiration cannula. I think this is the easiest instrument, and whenever the students are given a choice to hold one instrument and tell its uses, identify, this is the one they prefer, because you know identification is not at all a problem with this. So this is your irrigation and aspiration cannula. After the nucleus delivery, for the aspiration of the remnant cortical matter, you are using it. Now one more use, sometimes when your viva is going good and examiner is expecting something extra from you, and if you want to get that extra marks, then always remember it can also be used for the aspiration of the hyphema. Hyphema is again, you know, most common early post-operative complication of the cataract surgery, and many a times when we open the padding and bandaging of the patient on the first post-op day after the cataract surgery, you are seeing the blood inside the anterior chamber and you want to aspirate it. Maybe the pressures are very high and you can't just rely on the head end elevation or the bed rest. So for that you can do the AC wash. So for that AC wash also we can use this irrigation and aspiration cannula. Alright. Now the next one. Now can you see this? This is again a forceps, right? But this forceps are having the blunt ends, and again you can see a distance between the two prongs, right? So when you are having the distance between its two blades here, and plus they are blunt, so that means again it is a spring action, so it will have a spring action, and again it has a curved ends which will help in holding. So one trick and tip to identify the instrument is see if they are closed or they are having some distance. If they are having some distance, it is always a spring action, and whenever they are for the holding, right, for the holding, then they are curved upwards, and when they are for stabilization, right, then they are curved inwards. Okay. Now this is having the curved blades, and they are also blunt. So basically they are for holding, they are spring type, and they are there for holding something which is very delicate. So what is that? That is your non-foldable IOLs during the implantation. So the foldable ones are not that large, because you know when you fold it you require the smaller instrument because you are doing it in the smaller incision surgery. So they are the large curved ones. So when you are inserting the rigid one piece non-foldable PMMA IOL, this is the instrument that you are going to use. Okay, now see this. This is a very peculiar instrument, very typical kind of an instrument, which is called as the IOL dialer. IOL dialer. Can you see its step here? It is something like this. So it's like a finger, and this you will be relating well if you have seen those old telephone sets in which we used to dial the number by rotating our fingers over that. So can you see the shape of my finger when I dialing the number there on the telephone set like this? So it is the same shape they have made. See, after we have done the IOL entry and we are trying to keep it over the posterior capsule, you know that posterior capsule in the bag implantation or the capsular bag implantation is the most preferred site. It is the most preferred site for the IOL implantation. So in order to be sure that you are placing the IOL at the right position, after putting it we need to dial it. So if you have seen the IOLs, they are something like this, right? So we have got two dialing holes here. So these dialing holes will help me to place it centrally, accurately at its position, so that you are not getting the sunrise syndrome, the sunset syndrome, or the windshield wiper syndrome, the lost lens syndrome. For all those purposes, we are putting it and placing it, dialing it with the help of a IOL dialer. Alright. Then coming to the next one, this is your capsule polisher. Now this is not a very basic instrument, but still it is there. What happens sometimes when you are doing the irrigation and aspiration of the cortical matter, some amount of matter may be adherent to it. Okay, so in order to separate that adherent material which is actually adhered over the posterior capsule before the IOL implantation, you are doing it. So this is the instrument. It has a small bent neck, right, and then at the tip there is a very small ring. Now don't confuse it with the wire vectors that was having much larger loop, that was 0.3 mm, and this is having much smaller one, right? Okay, now we are coming to the instruments which are used in the DCR surgery. Now though DCR surgery is much less common in comparison to the cataract surgery, but because we are doing, and this is also the ophthalmology surgery, let's take a quick look over these instruments. Now these are called as a trifines, primary trifine, secondary trifine, and what happens, it has got a pointed tip in the middle and it is used to mark actually the frontal process of the maxilla and the lacrimal bone. The primary trifine. The primary trifine has a pointed tip. Can you see both are trifines? If you see the topmost portion, now if you see the tips, one has a pointed tip, this one is your pointed tip. So how will you remember? P for P, pointed tip is the primary trifine, and the one having the blunt end, this is your secondary trifine. So the moment you remember that the P for P, pointed, is primary, you can already know that the secondary is with the blunt. Now what are the uses? The one which is having a pointed tip will help me mark the frontal process of the maxilla, like here, and the lacrimal bone, because you know when you are doing the DCR surgery, you have to create a communication opening between the lacrimal bone and the middle meatus. So you require something pointed. And then second is your secondary trifine, that is having the blunt end, that is then used to make the opening. For making the opening, you require something hefty. You have to rotate it like this, so that you can make a good opening there. So for that purpose, we are using the secondary trifine. Okay. Now this is a important instrument, and I think this will also be easier to identify. This reminds me of that paper punch, when we are punching the papers to put in that spring file. So we are punching it like this. So similarly, this is a bone punch. This is actually Citelli's bone punch, and you know, when you are creating an opening in cases of the DCR, that is a large opening that you have to make between the lacrimal bone and the middle meatus. So obviously that chunk of bone has to be removed. So that is done with the help of this bone punch, and I have seen the consultants doing this bone punch. The crackling sound that you suddenly get moment there is a bone punch, you start remembering the carpenter's noise. So that similar kind of a crackling noise comes when you do that bone punch, and a large amount of energy is also required, because you know it's hard to do the bone punch and create an opening there. And by the time you reach to the DCR surgeries, you're already tired, because they are the infected cases, so they can't be taken in the morning. So once you're finished with all the surgeries, then you take these cases in the last, because these are the infected cases. So at that time you're already drained and exhausted, and then lot of energy is required for doing this. Okay. Then your next one. Next is a chisel. Now this is just like a chisel, like chisel and hammer, So this is just like a chisel, and why we are using this? Sometimes there are very small bones. You in the DCR surgery, you have done the main chunk of thing by the this your bone punch, and then you have to remove the small pieces. So with the help of this chisel, you are actually smoothing out the edges, doing all neat work. So at that time you require the chisel. Okay. Then coming to the next one. Now see, if you look at the its tip, I think it will become very easy to identify this. Looking at the tip, can you see you are having a conical tip, and it's a pointed, very pointed. So basically its purpose is when you are using any procedure to do over the lacrimal apparatus, so you have to do it from your outer opening, right? And what is your outer opening? You can see the punctums, because every time you know that this is your upper punctum and this is your lower punctum. Then you have to follow the vertical canaliculi, then you have to go in the horizontal canaliculi like this, then it is opening in the lacrimal sac, and then is your nasolacrimal duct that will be opening into the inferior meatus. So when I want to do the syringing, or when I want to do the probing, basically I have to follow these punctums, I have to go through these punctums, can be upper punctum or it can be the lower punctum. So I need some space there. Okay, so for that we are using the punctum dilators. So we have got the punctum dilator. We can dilate the punctum, rotating it in the clockwise and the anti-clockwise fashion, and see if now my probe can pass through, and we can do it later. If one punctum is not doing, you can try with a bigger one, or again you can try and then again try if the probe is now going, and you can carry on the procedure. So that is the use of the dilator. Now how do you do the probing? Can you see, this is called as the Bowman's lacrimal probe. It is just a wire kind of a thing, and it's a probe because when you are taking this probe inside, you have to see up to what level you are able to go inside, and it has got two ends, and both the ends can be used as a probe here. One is slightly blunted, one is slightly tipped, fine tipped. So you can use either way. If you feel like thinner one is now able to go, then you can go with the blunt one. Initially if you feel like that even that can also go, then you can start with the larger lumen also. So basically when you study the congenital dicryocystitis, so many things that suppose this is your eye, okay, and this is your middle canthus. We have a upper punctum, we have got the lower punctum right here, and then we have got the canaliculi right, they are opening into your lacrimal sac, and this lacrimal sac will open in the nasolacrimal duct. Nasolacrimal duct will be opening in the inferior meatus of the nose. Okay, now this has got a series of the valves here. We have got a lot of valves here in order to maintain the unidirectional flow of the tears. So what happens in cases of the congenital dicryocystitis? One of the valves gets enlarged. So this is actually called as what you call as the membranous occlusion. This is called as the membranous occlusion, and this membranous occlusion will clog this pathway, due to which you will be having the lot of accumulation of the tears, and they will be backflowing, and this will be leading to the tearing also. So you have to see basically that at what level you are having the problem or the occlusion, at what level. So when you study this, do you remember we studied that whether there is a hard stop or whether there is a soft stop? So what is the meaning of this? See, when you follow this, this is your upper puncta, this is your lower puncta, this is vertical canaliculi, this is horizontal canaliculi, this is your common canaliculi, right? So suppose I am inserting the probe here. So you are going like this, this. So when you are stopping here, so if you are stopping here at the level of the common canaliculi, you will get a soft stop. Then this is called as the soft stop. But suppose the occlusion is not at this level and you are going even more medially and you are stopped here and you are not able to proceed further, then here you will get the hard stop. More medially you will get a hard stop because you are actually touching this lacrimal bone here. So actually what is the meaning of the soft stop or the hard stop? I think this must be very, very clear to you now. So now we'll be dealing with a very important instrument, that is your enucleation spoon. So as I told you from before also that look at the shape of the instrument and you will not require the cramming of its name. Its name is enucleation spoon, and look at the shape of the instrument. It is exactly like a spoon, but you also have a groove here. Now what is this? What is this groove actually? This is the groove for the optic nerve. This is the groove for the optic nerve. So why it is required? Actually, it is called as a spoon because it is a spoon shaped instrument. So when you are doing the enucleation, now first of all you should know the difference between enucleation, evisceration and insertion. And if you know its instruments, you will be very, very thorough that why and where we are using, what is the concept behind it. Now see, all three are the destructive procedures. Now enucleation means that you are doing the removal of the eyeball, whole of the eyeball. Now suppose you are removing whole of the eyeball. It is something like this, right? Like this, and behind the eyeball you will have the optic nerve which is coming out, and then it is forming the chiasma from the other side. So the moment I have to remove this eyeball, I require something which can hook this optic nerve. Okay, so it can hook this optic nerve like this, and this is your handle here like this. So this is used as an optic nerve guide, because when you are doing the enucleation you have to remove the eyeball, and you will also required to cut a part of the optic nerve, because you know it is forming a chiasma with the other side optic nerve, and that procedure is going on. So this is for engaging the optic nerve during the enucleation, right? Now I'll be telling you about the evisceration and insertion also. Now see this. Second is your evisceration. This can be called as a curate, or this can also be called as a scoop. Evisceration curate or the evisceration scoop. Scoop means like you have ice cream scoops. Can you see here? This is your scoop. It is just like you cannot say it to be a spoon. Spoon is a larger cover area. This is scoop, like we take out the ice cream with the ice cream scoop. More circular kind of a thing, so that when you remove it you get the whole spherical. You know, when you scoop out the ice cream with ice cream scoop and you put it over the cone, you get that rounded kind of a thing. So that kind of instrument is this evisceration scoop. And evisceration scoop, now why we are using a scoop here and why not we are using the spoon here? The reason is that what is evisceration? You are cutting the sclera, because you know there you have to leave the sclera. Okay, in the enucleation you are taking out whole of the eyeball and you are engaging the optic nerve. But in cases of the evisceration we are actually giving the opening in the outer coat. So it can be at the level of cornea, or it can be at the level of sclera on the top. So right, so what you are doing, you are giving a opening in the fibrous coat, then you are scooping out the uveal contents, all things scooping out. So for that you require some scoop like thing or a curate like thing. Like when we do the DNC, then also you have to curate it out. Okay, so you have to do, then you have to place the artificial implant and you have to suture it back. So that is why in the evisceration you are using the scoop. Now there is one more scoop that is used, that can be used as a evisceration scoop. See, this is having a larger one. So but again, can you see the shape? It is not like a spoon. This is a scoop. So either you can get this kind of a scoop also, or you can get this kind of a scoop. And in the further slides you will see that even a smaller kind of a scoop can be used in ophthalmology, but that is even for a more small things, that is for the chalazion. So even a smaller to this scoop, if it is used, then that will be a chalazion scoop, right? Then coming to the next one. So this you have already seen, this is your Lacrimal's Bowman's prop, okay, that we were using. This is your punctum dilator, you have done this. Okay, now this is the small cup, a very small cup with a very narrow handle that is used for the chalazion. Can you see? Very tiny one. So this is your chalazion scoop. Now, what is chalazion and why you require the scoop here? Chalazion is a lid infection. It is the most common type of a lid infection that you are getting in the chronic people. It's a nodular one showing a lipogranulomatous inflammation. It is non-suppurative. It is non-suppurative, no pus you are getting here. It is different from external hordeolum or the internal hordeolum. It's not a sty where you are getting a pus point just on the outer side. It is on the inner side, nodular thick. So when you invert the eyelid, you get a large bulge there. Okay, so that for that you require to scoop out the contents. Now for scooping out the contents, you have to give the incision, and for giving the incision you need to stabilize. So for that you require separate set of instruments that we will be dealing. See, the IOL dialer we have already seen. Okay, now IOL dialer looks very similar to another instrument that is called as a iris repositor. You have to reposit the iris back. That is very evident from its name itself. Now, if you look at the dialer, the shape of the dialer was something like this, you know, bent finger kind of a thing, because it will help in dialing the IOL. But if you look at the iris repositor, the edge is little curved, because this will help me in swiping the iris back. So when it is required, it has two purposes. One is when irises come out, you know, iris prolapse is a well-known complication that can take place in the early post-operative period of the cataract surgery. So that is but obvious. So at that time I will use the iris repositor. But one more extra, to gain that extra edge, it will also help me in breaking the synecdoche. Right, whenever we have synecdoche, you know, posterior synecdoche, you know, anterior synecdoche, and I require something very delicate so that I cannot puncture the iris, I do not create any false holes there, I do not lead to the atrophy of the iris. So there again, in order to break that synecdoche, I can use this iris repositor. So both of them, the IOL dialer and iris repositor, are the sleek model instruments, and looking at the tip you can easily identify whether it's a repositor or whether it's a dialer. Okay, two-way irrigation and aspiration cannula, we have seen this. Wire vectors, it's a wire looped attached to a metallic handle, that again you have seen. Now the chalazion clamp. See, I told you that when you have to work on the chalazion, you have to scoop out the contents. First, you have to stabilize the chalazion. So, how to stabilize that chalazion? For that, we are using this chalazion clamp. In this clamp, what is there? Screw is there. You can put the chalazion in between this clamp, and then we can screw it, tighten it for the stabilization. Now, the one end is the solid end and another end is your ring end. Solid and the ring end. So, what you have to remember is that the solid part is actually kept on the skin side. So, again you can remember S for S. Solid side on the skin, and this ring portion has to be kept at the chalazion side. At the chalazion side. So, if you are holding the clamp here, so we can put the solid side here and I can invert it, and then the chalazion will come in this ring portion. So, you have stabilized it. Now, on the most pointed area, we can give a vertical incision. Why I give a vertical incision over the chalazion? Towards the conjunctival side, we give a vertical incision so that I can prevent the cutting of the meibomian ducts, and then after giving the incision, I will scoop out the contents. So, I have a clamp and I have a scoop, both are different. Now, one more clamp that is used in ophthalmology is your lid clamp, that is called as the antropion clamp or a lid clamp. Now, can you see this instrument? Again, you can see that it is a clamp. We are having a screw action, but look at its shape. It is much larger. It is engrossing whole of the eyelid here. Here again, you have got two parts. One is your ring part and one is your solid part. Okay, but here it is opposite. You are putting the ring part over the eyelid and solid part below, so that you can stabilize it, because here the purpose is different. You have to work on the lids. So, if I cover it with the solid part, I won't be able to perform it. So, here I am putting the solid part below and the ring part here, so that I can do the surgeries of the eyelids. Now, what are the surgeries that I need to do? Right, I can do the antropion surgeries, the ectropion surgeries, the ptosis, all these things can be done here. Okay, so previously we used to use a lid spatula. A lid spatula was something like this. Previously we used to use this lid spatula, but I think this one is a better. This is your self retaining also, and therefore we do not require assistant to hold. So, that I told you for the speculum also, self retaining speculum, because you know, if I require this spatula to be placed here, there should be someone all the time by my side till the time I do the surgery, holding the lid spatula like this, and only then I can perform the surgery. So, I think this is a better alternate. So, this was about the clamp. Then we have got a very delicate forceps. Can you see the tiny uh, forceps having very small blades, very small blades. This is for the most delicate part of the eye. When you are cutting a very delicate portion, that is your iris. Okay, so this is having very fine tools, so that you do, because you know, we at times require the teeth because you require the holding of the iris, but at the same time they should not be very large tools, so that you do not cause a trauma to the iris, and they are again having separated. Okay, so this will help me in cutting in the wedge shaped areas, in the cutting of the wedge shaped areas. So, whenever we require the iridectomy, we are require the cutting of the iris. It can be for the cataract, for the glaucoma, or you are doing the peripheral iridectomy, right? Or you are doing the optical iridectomy, anything, or you, even if you want to cut that prolapse tissue of the iris. Repositor is for repositing, but for cutting you require the prolapse tissue cutting. Then again you require this iris forceps, or sometimes there is some entangled foreign body over the iris and you want to remove it, then also you can use it. So basically it is for the iris manipulation. Okay. Then this was your Kalman-McPherson forceps for the suture tying, for the capsulotomy. This we have done. Now there is one more scissors. This is called as a De Wecker scissors. Can you see? This is a different kind of a scissor, and you can see a D forming here, D Wecker scissors, and this is making a typical V here. Typical V, I'll make it here so that you can see the blades here. Typical V it is making. So this is again a spring action and making a wedge shaped cutting. So this can be used instead of the iris forceps also. You can use it for the iridectomy or for cutting the pupillary membrane. Sometimes there is persistent primary hyperplastic membranes, you have to cut those, or you have to cut some adhesions, synecdoche, for all those. So it's a multi-purpose scissors that you can use it. Then this is a needle holder. Can you see here? See, holder here. So you do not have the blades which are very separate. They are very much close to each other, and the area is very small because this is actually a needle holder. Needle holder, like we were using the Macpherson's forceps also, and this is a spring action needle holder. This also can be used for the suture tying. You are doing the suturing on conjunctiva, cornea, sclera, extraocular muscles while doing the squint surgeries. So this option you can also use the spring action needle holder. Okay, now I told you that there is one more instrument that can be used in place of the lens expressor, and that is called as a muscle hook. Look at the shape here, it is again L shaped. I told you L for L, lens expressor. Then how come this is a hook? See the tip here. The tip is rounded because this has to be hooking the muscle, which is a delicate belly. Extraocular muscles are very you know, delicate. So at that time we are using the blunted area, but otherwise both can be used interchangeably. I can use a lens expressor instead of a muscle hook. I can use a muscle hook instead of a lens expressor, right? So when I'm doing any surgery where actually we require to deal with the extraocular muscles, basically the squint surgery or the enucleation surgery, or when you are doing the retinal detachment, scleral buckle has to be placed and 360-degree and clutch operation has to be done. That time also you need to hook the extraocular muscles. You can use this muscle hook. See, this was your lens expressor. Can you see here? And this is your muscle hook. Can you see? When you see them side by side, you are able to recognize which one is your muscle hook and which one is your lens expressor. Okay. Now comes to important instrument. Now here identification is not a problem. You can see the calipers here, right? You can see the markings here. So basically this is a Castroviejo calipers which is used for the measurement. So where do I require the measurements? When I am doing the squint surgery, I require perfect measurements. When I am doing the torsus surgery, I require the measurements. Or when I am doing the PPV, pars plana vitrectomy, in order to make sure that I am going through the pars plana, you have to measure the distance from the limbus. Again, I will be using it. Or suppose I want to make it, whether it's a microcornea or it's a megalocornea, you have to see the iris diameters. At all those places, we will use this Castroviejo calipers. C for C, Castroviejo corneal calipers. Basically, it can be used for the corneal dimensions also, right? Then you have already done this. Universal metallic eye speculum can be used for both. So you have done this. Now this is a very interesting instrument. It is just like a snake sitting here. Dasmer's retractor. So it is actually the saddle shaped, folded on itself. This is basically one instrument which is very polite, but it will help in examination of the eyeball. Sometimes the children are not cooperative and you can't be very harsh on them, or maybe the congenital glaucoma where there is a blepharospasm. So for those purposes we can use this Dasmer's retractor in order to retract the eyelids. So the moment you see its shape, you will see we can hook the eyelid and we can retract. So this is basically used for retraction of the eyelids. So this is all for the instruments. I think most of the instruments that are concerned with your NEET PG examination, your prof examination, the FMG examinations, I have covered, because these are the most common surgeries that you study in ophthalmology, and because you know this is not being very much covered and you're not so much exposed to these instruments in your third years or while you are doing the internship, it becomes at times difficult to undergo the understanding of these surgeries properly. So I have tried to cover the theoretical as well as the practical part of the instrument, basically how to identify the instrument, and based on its identification, what are its specific uses there, you can use it. So I think this will be helping you. Do write me in the comment section, did you like this video? Please like, share and subscribe. Share this video to your colleagues whom you think are needing this video, so that we can reach the maximum students who need this in the times of the COVID, especially when the students are not able to go to the wards. They are really missing it, and that's why I tried to cover up this, because I was getting so many messages on my mailbox that we require a discussion on instruments and make it happen. Thank you and happy ophthalmology.